And I'll just start us off by saying welcome to everybody for our second question and answer session for this special edition case as a joint effort with the Mechanical Care Forum and the McKenzie Institute USA to review these three videos that Scott Herbowy has brought to us from a patient that he has seen several years ago as a learning tool during this unusual time where some of us are locked down, others are beginning to reopen, some have been reopened, but at any rate, some courses at least have been put on hold for a time being. So we thought it would be great to be able to reach out and extend at least some communication and some content and some chance to discuss some good clinical discussion. So we want to welcome Cora Aytona, Dave Oliver, Scott Herbowy, and Gary Dykes for being on our panelists tonight. Thank you, guys.
Thanks for having us. You're welcome.
And so what we'll do right now is go ahead and jump right in. We've had the first session, the video, which was the initial evaluation that Scott did on Brian, a 44-year-old male with anterior right knee pain, who had about 2-week duration of symptoms. Scott found that he had an obstruction to flexion as well as a minor loss of extension with pain in both range. His baseline was were flexion and extension as well as squatting. We had some good conversation as to some of his clinical reasoning in the history taking, as well as through the physical exam and into the repeated movement exam. We've got a guest tonight, panelists that we're excited about having. We're hopeful that the panelists can bring more to us from a clinical perspective than the pooch can maybe, but at any rate, let's do this. We had some great questions that were brought up, we'll go ahead and try to disperse these questions across the panelists, but also give Scott a bit of chance to maybe describe what his thoughts were through these. So let's first talk a little bit about some of the questions that you asked initially, Scott. Your first question was, have you been able to do the exercises that I prescribed for you? Your second question was, are you overall better, worse, or the same? So we didn't have any specific listeners, attendees now, who asked the question, but I'm going to ask the question just to start us off since that was the first question. Are you methodical in how you start each session, or do you let that vary? Can you talk about that for just a minute?
No, I think you're right. I do have a pretty distinct structure with some variation that I follow. You know, the first thing, compliance. It's a big difference between, yes, I've done it and I'm the same versus I didn't really do it, I'm the same. And I always try to phrase it in a non-threatening way. So instead of saying, did you do your exercise? It's, were you able to do it? And, you know, the most common response is, well, yes, but not as often as you wanted. So then typically it becomes, okay, so how often were you able to do it? And, you know, the big question is overall, better, worse. No microcosm of time is that important because pain is dynamic. You know, I'm a little better in the morning, I'm worse in the afternoon. Well, if you look at that morning, hey, I'm cured versus the afternoon, no, I'm worse. Well, it's neither. So it's the big picture. What is the big picture here? So that's what I'm trying to get at.
Gary, I know that in times past, you and I have talked and you've mentioned how you're quite methodical, and the more you've done this, the more methodical it seems like you've gotten. Correct me if I'm wrong. What do you have to add to what Scott's mentioned?
No, I think that's definitely a fair statement. And I'm just writing some notes down here as we go. And it's, you know, I think that I say this all the time. I said it today, even where I had someone come back for their second visit. I think that we learn the most from the second visit. And that is that, you know, the patient comes back and, hey, I did exactly what you said and here's what happened. So we got new information. Or they came back and say, hey, listen, I didn't do it as much as you asked or at all. And they learn that we can't make decisions clinically unless they comply. And you further explain how the process works. And so I think that the second visit's probably, I think I look forward to second visits as much as I do first visits because of that reason. And it is very structured. As Scott pointed out, there's a bit of information here, and all of our expectations is, you know, is kind of leaning on that, waiting for that information to come to us.
Jason, could I jump in one more time on that? I think all of us here and people who are experiencing this, you do develop a methodology, and I think, and I encourage people to do that, but you can't be dogmatic on the same side. You need to be methodical, but you need to be flexible. Yeah. So methodology, great. Dogmatism, not so good.
Good. Cora, what do you have to add to the structure, and what's key in your mind as to what you're wanting to make sure you acquire on the first few minutes of that second visit?
I have very little to add as far as that is concerned, because I do things pretty much the same way. I believe in structure, and a lot of it has to do with being able to fit in and gather the right amount of information within a short period of time, because typically the follow-ups are going to be a lot shorter. You don't have a whole lot of time to waste. So if you start asking questions like, how are you doing today, and not being methodical with your questioning, you're going to end up spending a whole lot more time with it. So having the structure not only helps you with your diagnostic and clinical decision making, but it also helps you with your time.
How do we reconcile that, Dave, when we think, okay, the number one thing that we've got to do is build rapport with the patient early on? Is there a value in asking Miss Jones how her day's been so far, or does that lead to us running down a rabbit trail that does maybe take a bit more time?
Yeah, I mean, I'm actually have another comment coming in a second, but yeah, you have to have a rapport with the patient. I don't have a patient walk back into the clinic and just say, are you better, worse, or the same? Sit down and tell me, are you better? So yes, I mean, I have that conversation. I meet the patient in the waiting room. Hey, how's your day going? Come on in, sit yourself down, and then I'm going to start extracting that information. The one thing I wanted to add, and the one thing that I've over the past few years that I've been doing, is one of the comments that we always get on classes, and I always ask people at the beginning of class, what problems do you have? And one of the biggest problems that people come up with is compliance with their exercises. My patients just don't do the exercises. And just talking to other faculties, is generally we're so concise in how we deliver what we're doing and what we want them to do. The general consensus is we have pretty good compliance. The one thing I've been doing the past few years, though, is I've even preempted them on leaving after their first visit of what I'm going to ask them when they come in for that second visit. So there goes. So I have done the assessment, I've done the education, I have given them an exercise to be doing. I've told them the reason for doing the exercise, what to look for, what to check for. I've given them the dosage, and usually it's on a piece of paper. And then I'll tell them, I said, okay, now next time you come in, the first question I'm going to ask you is, did you do this exercise? Or were you able to do this exercise? The second question will be, were you able to do it as often as I wanted to do it? The third question is what was the effects of doing it? And I've also dished out, I'm looking for symptom response. I'm looking for maybe mechanical response. I might have them self-assessing their movement. And I might also be looking at functional, can I go for a run? Can I do this activity? So, well, I want you to test that activity. So they can actually give me some quality information as they come back in.
Other thoughts on that, Vinny? I think that establishes how important that second visit is. Scott, you did mention that, or your next question was, when Brian told you he was 60 to 70% better, you asked what makes you say that. You instructed the diploma program for some time. Was that a question that you did hear many clinicians that are a little less trained or earlier on in their career asking, and what's the importance of it?
Well, certainly the importance is getting good data versus the patient's opinion, because early on, Robin would tell the story. People came back centralizing, saying they were worse. We've all heard that about, my back pain is worse and da 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 da. So whether it's better or worse, if there's a perceived change on the part of the patient, I need to know, well, not why do you say that, because they'll say, well, the exercise, but what makes you say that? And I'm looking at those baselines. Are they describing, number one, in importance, a symptomatic change? Number two, is there a functional change? And then lastly, a mechanical change. And I want to hear them describe that. I'm not going to accept their, yes, I'm better, unless I hear one of those justifications. Mm-hmm. It's easy to say, yeah, great, they're better, hooray, hooray, but are they really better? And I think in a diploma program, that wasn't one of the big things that we saw that people had difficulty with. not that I can recall off the top of my head. So if I don't recall it, I don't think there probably was that big of a problem with it. So I think most people are pretty good on reassessment and getting that information.
Any other thoughts from the panelists regarding how we might be misdirected from the patient if we just leave it a simple question and then move on?
Yeah, I'll add something to that. I think that as young clinicians, I mean, not just young MDT clinicians, but young clinicians in general, you know, we're so excited to hear someone say they're better because it de-stresses us instantly. It's like, oh, okay, great, you're good. So we feel like, okay, I'm not going to ask any more questions. I've heard what I need to hear. I'm out, you know. Let's just do a lot of the same stuff. But I think that, you know, when people have good results and they hear the next question is like, okay, well, how is that you're better? Even for the clinician, you've got to be comfortable with what you're going to hear next, because if you don't want to hear it, you shouldn't ask. And I think some people just are fine with, I'm good, you know, and you got to know the answer to that. I want you to quantify that to me, convince me that we're good, you know, and so I think that that's a question sometimes I think as a young therapist, some people are not just like say young MDT therapists, but just in general, young therapists are not ready for the answer. And so you got to be willing to be a little uncomfortable. I always say that.
Very good. Dave, his next question, one of the next questions was, what, if any, effect did you have from the exercise at the time of doing them? How can we, if we're not careful, ask that question and get some poor or inaccurate information?
Well, you can always get inaccurate information from the patient. So I think it comes down to just kind of like picking away at the information. And again, I mean, an exercise is prescribed to the patient with the intent of it affecting the patient's mechanical symptomatic presentation. And again, it all comes down to, you know, the patient, I mean, the patient's saying I'm 60 to 70% better, and then the follow-up question, in what way you're better? It's less painful to go up and down steps, to walk, to squat. Okay, we're establishing this. This is a big, bright green light. When you ask the question and you have to, I'm trying to think what I was going to say then. You actually, what was I saying?
I have another.
We were talking about he was asking specifically targeted at the time.
Oh yeah.
That's what effect.
Yeah. So basically, I mean, if a patient comes back and they say, well, I'm just the same. Well, we're trying to establish is this exercise having any impact on that patient's current situation? So if the patient says, well, I'm about the same, but when they do the exercise, there is a significant change, whether it be better or worse, we can start to establish the effect of that particular exercise. So it's just, I mean, again, I think the initial follow-up, and I've done this on classes and I do it in the clinic, is that, you know, the initial interview of the patient could be numerous questions, you know, constantly kind of cross-examining the patient to establish, you know, are we moving the right joint? Are we moving the right joint in the right direction? And have we got the right load right now?
Mm-hmm. Anyone else had any additional thoughts on that initial interview, those first few minutes of that second visit before we start rechecking and beginning to, you know, check and see if the patient's performing the exercise correctly? If not, we'll move right through here. Okay, let's do that. Lots of questions from the listeners and from those who viewed the video regarding loading strategies. So Scott, give us a first indication in your mind as to the patient comes back, they're quite a bit better, they're not fully resolved. Your first thing that you did then is checked his functional and his mechanical presentation. And with what he showed, what did you take away from that?
Well, you know, again, he was clearly better, and in some respects, his functional baseline to squat, yeah, it was somewhat better, but I think there's a couple of things to consider, and I know that, you know, as you said last week, the elephant in the room. Okay, so why did you make such a big change there? He only had pain for 2 weeks. This is not something that's been there a long time. It was 3 days from the first visit, so if he's doing 10 or 15 reps 5, 6, 7 times a day, he's already done 200 or 300 of the extensions since the first visit. And my experience, and I think a lot of people will tell you this, Robin used to say, well, necks are easier than backs, and extremities are even easier. You'll see dramatic changes with just a low number of repetitions in the extremities. And, so even though you might be impressed and say, wow, 60% better, at that point, I'm thinking, well, okay, I'm kind of greedy. I want a little bit more than that. And, patients, especially, Brian, a young guy, athletic, wants to get back to things. Yeah, it might be, it embellishes a little bit. Is it really 60%? Because his clinical exam, I wouldn't say reflected 60%. I think it was, marginally better. Squat, not better. Well, why is this not better? Well, let's get it more aggressive and let's load this thing up, knowing that the extremities tend to change quicker and the majority of lower extremity derangements do need weight bearing for full resolution.
Sure. Cora, we were preparing for this, had a few minutes of discussion beforehand. Because your question was quite similar to some of those that viewed the video and sent in their questions, I'm going to let you ask Scott, what specifically was your question about him moving from the prescribed home program to what he did next?
What do you mean as far as going from sagittal to lateral, or progressing from self-generated to a little bit more overpressure and standing?
Yeah, it was the progression of the load that you're,
Yeah, so I mean, can I just comment a little bit on the first question that you asked, Scott, as far as why, because I'm sure a lot of folks have that in mind. If a patient comes in and they're 60% better day 2, why change anything? Because we're always taught green light, with green light, you don't mess with it, just keep doing more of the same thing. But I would agree with Scott, just because with the extremities, the response is a little bit quicker. So you can be a little bit greedier, but I think it's important to note that it's not wrong to continue doing more of the same thing and be more patient with it, and maybe pursue that for a little bit longer. Maybe more time would have gotten that patient to a more significant improvement. However, I think we have to take into consideration the individual. We have patients who are coming with high copays. So if they're paying like $40 to $60, it's a matter of getting that patient better in a matter of 2 weeks versus 3 to 4 visits. All right, so getting that patient better in a shorter period of time might entail a much quicker force progression. So I tend to be a little bit quicker with my force progression as far as the extremities are concerned. Now going into the next question, why is it that instead of going from partial weight bearing, why did he go into full weight bearing and so being a little bit more aggressive with the force progression and skipping steps? And I think he already answered that. He said the majority of extremities, especially lower extremities, we do a lot of loading, weight bearing with it. So I think that comes with experience as well, right? So he knows that at some point I'm going to have to load him. He's not that irritable. And it's a matter of knowing, do we need to keep going in the same direction, or does this patient have a relevant lateral component? So I do understand his thought process. But again, it's not wrong to go a little bit slower and follow a less aggressive path.
Gary, Dave, tell me what your thoughts are and maybe how you might have, just based on, of course, we're limited, having just seen a small snippet of the evaluation and not being there in person, which may change your opinion. But Gary, you have any thoughts of how you might have addressed this patient on that second visit, different from what you saw Scott do?
No, I think that the way I package it might be a little different, in that I may not look at it as I'm looking at, let's just go, until we, I think that one of the ways I'll do that is, okay, I feel like if we have that great of a change and we can see that, then we can, the first priority would be to classify it. So we say, okay, we got a derangement, so we're going to work within that classification. And so am I prescribing them? Am I giving them the correct, direction? Sounds like it. Is it the correct force? And so I'll educate the patient on, we always have this to fall back on, but I'm not sure it's exactly what you need to do to continue to improve. So they know that, if we push, that we end up maybe get an adverse response or worse, then we can always fall back on what we had. And so, like Cora was saying, I think it allows some ability to come back to where you were and be patient versus moving forward always. And so the way I educate the patient early on is that, you know, we're going to look at, is this the optimal way to do this? And if it is, then they leave doing the same things. If it's not, then we find something different.
With a patient coming in, and then when the progression of load did occur, they regressed, saw a quicker, more intense symptom through that squat, their flexion then re-obstructed. What are your thoughts as to what's happening in the joint? And when a patient asks, Dave, what do you tell the patient in that situation?
I have no idea. I mean,
you can't remember what you said.
You came with the anatomical question to me. It was like,
it's the meniscus.
I think there's a little bit of a meniscus scooting around in there. It just needs to be pushed back in the right place.
Yeah.
No, I mean, and again, I mean, when I talk to patients, and I don't talk very anatomical with them. I talk about joints and hinges and looking for direction. And I do talk to patients. You know, sometimes you can move too far too fast. I think, coming back to Scott's comment, which I think is very valid though, is he's coming in going, I'm 60 to 70% better. He doesn't look 67% better. And he looks maybe 30% better. And if a patient came back and said, I'm 20 to 30% better, you would do something. And there's the argument right now, well, he's got a green light. Well, let's see if we can make it greener. Let's push it a bit harder and then see if we get the response. And if it goes greener, then we're laughing. We can check all our boxes. It's the right joint, the right direction, the right load. But the light turned red. All right, well, we got to start taking a look at this. Now, if you progress and you get a red light, then the first thing I tend to do is I'm going to regress. And then Scott went back to doing some of the original exercise. Well, some partial response. But when you get to that point, it's like he didn't look as good as what he was describing, at least when he came in. So you need to make a plan. One thing, just talking to Scott earlier, there's options. There is no recipe at this stage. You know, you've started moving them. We've established it's a knee. We've established it's a derangement. It's got rapid change, and we are starting to work towards. Well, we believe we may have the right direction because we've already got a green light right now. The question comes down to, well, what is the loading strategy? I often will go in the direction that Scott went and just take a look at that lateral tibial rotation. But the one thing that I'm using more in the clinic is using different loading strategies. The one thing I might be exploring in the clinic might be using resistance, and going, okay, we've got direction, we've got a green light with extension. I might explore the use of resistance in the direction that we're working in.
Dave, is there something that the patient showed that gives you the hint that they might have also responded really well with a significant further improvement with the resistance added?
I don't think there's anything specific apart from the fact that we start exploring a direction. We've got a green light on day one. The light is still green on day two. We tried to make it greener on day three, but we get a red light. It was okay. Well, how can we adjust the load? Now, we are doing unloaded exercise right now, and he's got a problem with a weight bearing activity, and typically with lower extremity joints, we're going to be exploring loaded exercises. But we went there, and then you've got options, and it was like, well, is there another way to load this joint in the direction that we're continuing to pursue? To see if we can get a green light at that point. But, you know, I think it's 6 of one, half dozen the other. Sometimes I might pull out some TheraBand and look at some resistance exercises. And sometimes it's easy to go, you know, let me have a quick check, especially when I see a squat like that, a weight-bearing squat like that. Often I'll jump straight in and mobilize it into rotation, into extension, just like Scott did, to see if I get a response. And if I get a response, then I'm going to run down.
Got it. Scott finished his initial history taking. He checked his concordance sign. He asked the patient to demonstrate the exercise, and he said, let's do a small set of a few repetitions. in my mind, I'm thinking, let's have him do exactly what he's been doing to see if what he's reporting actually occurs right now, where he gets momentary further improvement. Cora, do you have the patient do exactly what they're doing at home and let them do a full set? Or once they've demonstrated that they're doing the exercise correctly, do you move on and think we've got to progress the load, change something to get a further improvement?
See, that's something that I would do a little bit differently. I tend to have them perform the exercise and the frequency, I mean, the repetition, just like they were doing it at home. But I think, if I remember it clearly, Scott asked Brian if he had done the exercises prior to going into the clinic. Isn't that correct?
That morning.
Yep.
Yes, so I think he said he had done a couple of sets of 15 repetitions prior to getting into the clinic. And so I think at that point, he was already confident that even if the patient, if Brian did about 5 or half of the usual repetitions, that he would be getting the same response. But typically when I do my review or reassessment with the patient, I would have them do exactly the same repetitions, just because I want to know if they're doing it exactly the same way, and if is there any corrections that I need to make.
Right. Gary, we've all had those patients who real eager. They've had a 10 minutes wait because you're a little slow down in Georgia, and they've already done 3 sets of 15 repetitions. They've already done 3 sets in the waiting room, and then they come back because they're just trying to help you out by getting their knee warmed up and prepped. How does that change what you assume or how you view that patient?
Well, I think it goes back to what Cora and maybe Dave was talking about with, in Scott's question was, how recent have you done a set? Because sometimes even in the morning, they'll say, well, no, I was waiting on when I came to see you. So, and it's, that's not ideal. We want them to go straight away. Let's get going first thing in the morning, last thing at night. Right. But I also look at that opportunity as if they have not performed them recently, that I have a clean slate for baselines. So if I'm going to test a different loading strategy, I can go ahead and test that loading strategy, after just a quick check of how they did the one prior. So if they did it properly, you haven't done it today, here's my baselines, and I feel like I can test a new test move at that point a lot easier. If they've just done it, then if they come in the clinic, then I would anticipate that those baselines I saw the first day would be better if it was the right strategy. Mm-hmm. So if they just did it, they can demonstrate it properly. I'd get a quick look at that, make sure it was right. They've done 30 reps in the waiting room helping me out, then they better show me improvements, right? So that would be my expectation. If they don't, then I'm moving pretty quickly to something different.
Okay. Dave, Will asked the question, is there any particular reason that Scott performed loaded knee extension with the tibial external rotation and didn't test repeated semi-loaded knee extension with tibial external rotation first? Do you find that you see that you would do partial before going loaded, fully loaded on single leg stance, or is there not necessarily that progression in the extremities like we understand in the spine?
As I mentioned earlier, so most lower extremity joints are going to require to do it in loaded at some point. In order to get that tibial rotation, you really need to have the foot planted. Now, sometimes I'll do it maybe partially loaded, so in weight bearing with maybe like 50% weight through both feet. But you've got to have that foot turned out. You've got to have it planted in order to apply that rotational force to it. Doing it in the sitting position, like the original exercise, I find that just is not effective. If the patient, and again, some of the comments with regards to going to actually doing the mobilization or the overpressure first, to instruct the patient to do this correctly and do this well, it takes time. So before I'm going to take that kind of time to show them how to do this technique, I want to make sure that this is the technique I want them to be doing at home. So go into the overpressure first and actually have it doing them in line first to get a clear picture whether this is going to be effective. But then pretty much always I'm going to get them up into at least standing, at least partial weight bearing. If they can tolerate full weight bearing, they'll go straight to full weight bearing.
Okay, all right. Hans asked in the questions, you're using the squat as a baseline. Any reason why you chose that baseline rather than the passive flexion in lying, which also got a lot worse after the extension with overpressure in weight bearing? Scott, what was your thought process there?
I'm sorry, Jason, the internet broke up halfway through what your question. So if you could repeat it.
Yeah, of course. Hans asked the question, you're using the squat as a baseline. Is there any reason why you chose that rather than the passive flexion, which also got a lot worse after the extension?
I think it goes back to the earlier discussion about methodology. You'll see a lot of knees that unloaded flexion doesn't really have an effect, no different than maybe flexion and lying for the lumbar spine, but either flexion and standing or flexion and sitting might have an effect. So I test as a functional baseline a lot of knees with a squat. Probably the number one thing I do with knees as a functional baseline is a squat. Probably second would be stairs. Probably third would be actually having the patient run. So, I think that's maybe the methodology rearing its ugly head or probably beautiful head, I should say. I tend to look at a squat, I want to load that joint. The knee is arguably, if it's not the first, it's the second biggest joint in the body. It's built for load. Let's load that thing up, and let's see what happens with it. So, and functionally, just like we look at sitting position, and how many people report with a lumbar spine that sitting is an issue. I think you can say the same thing about the knee. How many people with knee problems report that squatting was an issue? Yeah. I don't hear a lot of people say laying down and bending their knee up is an issue. Now it might be clinically, but I look at that pretty consistently and pretty frequently.
Cora, what are your thoughts on what Scott's mentioned?
I would agree, because I think it would be more meaningful to check functional baselines rather than just range of motion measurements. I mean, it's not wrong to go back and recheck it, but sometimes you can overdo these baselines. I've seen a lot of clinicians who celebrate all these test baselines, and then you end up flaring up or irritating the joints even more. So I think if you're in the process of confirming direction and also classification, sometimes what you do is you just give it a load or a set of a certain loading strategy, and then go back to something that is readily accessible at that particular time. And I think squatting down would be, in this particular case, was more accessible and more meaningful.
Sure. Very good. There was some very specific description and coaching, Scott, that you gave Brian, having him put his hands on the muscle, turn the muscle in. I thought that was interesting, and I wondered why you used that phrasing specifically.
Well, because if you just reach down and grab, there's so much soft tissue slack that most people, if you don't take up for that soft tissue slack, you can't get the good rotational force around that joint. So I'll use that in the mobilization when I'm doing it. When I teach it, it's also the clinician, you take up that slack. I use that for patient in the knee. I'll use that actually teach the same strategy for the patient for pronation in the elbow with extension and or with flexion. So it's important, again, to get that optimal force that you're looking for in that joint.
Okay. Any of the panelists want to share some different handling, some different description that maybe you might have found success with when you're trying to have a patient add internal or external rotation along with the sagittal plane movement? Dave, you look unassuming.
No. No, yeah. I mean, you've got to get a good bit of thigh. You've got to turn the foot out, and you've got to turn. I mean, I'll sometimes as well make sure you kind of turn the pelvis slightly, because you want to get the torque through the joint. If I'm doing it up against the wall, then you get fixed. But if I'm doing it in like partial standing, I'll make sure they kind of twist the femur. But no, I mean, okay. We all do it the same, I think.
Any position or time where you're going to have a patient put one hand above the joint and one hand below, if you've got someone flexible enough to do it now?
No.
Any other alternatives?
It's very difficult to do. You typically need to have, because your thigh, I mean, unless you've got a tiny.
Demonstrate that for us, Jason.
I'm just trying to think outside the box here. If in fact any of you guys had any differences in how you do it.
If I'm doing flexion with internal rotation, I'll grab hold of the tibia.
Remember, Jason, the lower leg is fixed on the floor, so even if you're able to grab below the knee, you're not going to be able to get any rotation on that thing anyways, because the lower leg is fixed.
Good. All right. A question has been added this evening. Had the patient continued to exhibit a regression with the loaded internal rotation, external rotation force, would Scott typically have sent them home with the original exercise, or would have continued looking with more extension flexion? Scott, what would you have done?
Look, we had a green light with the straight partial weight bearing extension. So if I had the full weight bearing worse, I think the question is if the rotation extension maneuver made them worse, what would you look at? And I think I would have gone back to the extension partial weight bearing, but maybe looked at some force alternatives. The one thing that hasn't come up, I could have just simply had him sustain at end range and see what that had done. And I think Cora's point was, really beautiful for people that were feeling like, well, gosh, this guy's 60% better. Why are you changing things? Wouldn't be wrong to send him home for another couple of days with that. I tend to be, again, pretty aggressive with those with extremity joints. So I think you get worse with loaded extension, worse with the rotational component, back down to what you had that was working. And which I did when he got worse with full weight bearing. What did I do? I went right back to the partial weight bearing. Let's give that another chance to work. But again, based on experience, I thought, well, let's go to this rotation. But if that fell apart, I think we got to go back to the extension and look at alternatives. Maybe sustained. I like Dave's comments on resistance. So there's always things to look at.
When we consider resistance, what are you finding that's more commonly successful, Dave?
Actually, I'm interested to see what other people's opinion on the group is with regards to this. I mean, what I tend to do is I tend to do resistance in a weight-bearing position with TheraBand around the knee, but I tend to have the TheraBand wrapped around the front of the knee. So the actual resistance is actually facilitating in the direction of extension and having the patient slowly feed the knee into terminal knee extension. But I do know some people do it the opposite way and actually have resistance into it with the band around the knee, at the back of the knee.
Yeah, you're saying that the band is in the front, anterior knee. It's pulling them into. It's actually an assisted extension. Got it.
Yeah. So and again, that's my go-to, and I've done both. And that's my go-to based on I think I've had more success doing it that way. But I've definitely heard from other faculty that they do it the opposite.
Anyone else want to chime in about, are you using any resisted band with knees?
I do the same. I use both in full weight bearing with the band around the front of the knee. And I used to, a long time ago, however long that was, would put the band behind the knee. And I think I've gradually, I probably learned it from Dave, go to the front of the knee, and I think I find better results with that. But if that doesn't work, then I'll go behind the knee.
Okay. John's asking, go ahead, Cora, go ahead.
No, I was just going to say, I mean, obviously Scott has seen a whole lot more knees than I do, but I tend to compare the knee to the lumbar spine, because I think, just like we've mentioned before, the elbow and the knee, they behave very much like the spine. So I don't use resistance as much. So I probably would do it the same way as Scott did. So if they tend to be worse in extension, then I would go right into rotation, or so I'm going to rule out lateral component. So if they get worse with that, so because my thought process is, okay, do I have the right direction? Okay, so force progression in the sagittal plane, in this case extension, made it worse. It's just like in the lumbar spine, you keep going, adding force into extension. What do you do next? Then you do hips off center. So for me, with the knee, I would add rotation. And if they get worse with that, and I had better response in the sagittal plane in extension, I would go back to extension. And then I'm thinking maybe it was too hard too soon versus having a relevant lateral component. So I would explore that more before I would go into resistance. I'm not saying that going into resistance is wrong, but I tend to be more following a very structured approach, just like I would with the spine.
And in a way, Scott, were you giving the patient in supine, so you had the patient worse and they regressed a bit from that single leg stance loaded. You then tested your own manipulation of the tibia into external rotation in a supine position with your proximal hand at the knee, having him resist, or you're giving him resistance into extension while he sets his quad. Why did you choose to interject that in the midst of his self-generated forces?
You mean with the mobilization?
Right.
I don't think I'm actually giving him resistance. I think I'm giving him something almost proprioceptively to push against, rather than I'm trying to pull him away from terminal extension, because that mobilization, you're extending the knee from proximal to distal, and most people are used to extending from distal to proximal, so you have to give them that proprioceptive feedback. And I will actually, before I do that mobilization, work with the patient for, I don't know, whether 4, 5, 6, however many reps it takes, so that they learn that, or so that they know that their job is to extend again from proximal to distal, rather from distal to proximal, you know, raising the ankle up into the air. So it's not really resistance. It's just, again, I think a feedback loop for them.
Tactile feedback. Okay. Okay. Anyone else have any alternatives that they do and they're trying to quickly get an answer, perhaps in the supine position with some a mobilization like this? Maybe not. That's
I do it the same way. It says you've got to give them some kind of guidance. You know, do you tell them what, you know, before I even put the rotation on, I tell them that their job is to straighten the knee, push down into my hand and bring the knee to terminal knee extension. And then my job is to apply the rotational force.
Okay. All right. John asked the question, with the resistance band as described, can you also do a rotational aspect? Gary.
I have not. I guess I suppose you could create something, but I guess if you're a closed chain, you could pre-position the tibia externally, like you could toe out and focus on medial rotation of the thigh as you do that. I suppose you could do that with the resistance band. I don't know that I've ever done that. Maybe
I've played around with it a few times. I've put them in.
That would be more of a pre-position for for what you're doing, rather than actually eliciting that force.
I've had them turn the foot out, pull the thigh in with the band around and slow it. It's kind of like, not something I've sat there and thought, oh, this is a great technique. This is something where I'm like, I gotta kind of just tweak. This is like an outlier. I've got to kind of tweak the technique slightly.
Sure.
That maneuver violates Robin's #1 thing. This is getting too complicated.
Absolutely, it is. It's like, what am I doing
It's
there?
like they got a whole here with a band here and a here there, and it's like, oh boy. All right. And I'm like Dave. I have played with that a few times, but I never saw it to be anything magical, even with, you know, the lone patient. So I never pursued it very much. But I mean, it's a very logical thought process, so it's a good question. But I never found it to be anything that made me go, wow, I think I need to play with this more.
I mean, I think I've played with that before when I found that the actual mobilization is very effective, but the self technique was not as effective. And I'm like, I'm just looking for something else that they can do themselves. But again, the same thing. It's like, I've done it like 2 or 3 times, but I'm not doing it much because I found that, you know what, it really doesn't offer me anything of that much value.
Good. All right, I'll just mention this. We've got another 15 minutes, so any attendees that have additional questions, please feel free to add those into the chat, and we'll try to address all those that we can. One thing that I failed to mention early on was there was a question, why, Scott, did you have the patient come back in 4 to 5 days as opposed to 24, 48 hours from that initial evaluation? Perhaps it was the context of where you were evaluating this patient, or maybe you would have preferred that.
I think in the ideal world, it's, you know, when I was in New Zealand, the rule was you saw a patient daily until the derangement was fully reduced and maintained. You know, I think most of us now, we don't have that luxury, you know, for whatever reason, whether it's patient scheduling or finances or insurance limitations or something like that. I still try to see patients after the first visit, you know, within 24 to 48 hours. It's not always possible. And honestly, in this case being, I think it said 2000, I think I looked at it when I watched the video today and it had the date on it. It's from 6 years ago. I honestly don't recall why he might have come back in 3 days, whether it was an insurance thing or it was, I said that.
If they were in your clinic, what might you have had Brian done to do?
Well, ideally, I like people back in 24 to 48 hours after the first visit, especially something this is acute. It's only 2 weeks. It was starting to change fairly rapidly. You know, let's move this along as quickly as possible. And Cora's right. We don't have the luxury these days. You know, people, she said 40 to 60. Where I'm at in Texas, one of the big employers there, the copay for the people coming in is $80. And people with $80 copays are not, you know, I had people come in and say, look, I can come for 3 visits. I'm telling you this ahead of time. So, you know, we need to get on with things with these people. You know, as times change, efficiency is going to be more and more valuable.
The questions raised here tonight from Andrew: any patterns noted in assessing for motion loss and tibial rotation to identify the potential need for that rotational component? Are you guys testing for that? Or are you staying sagittal, and once that shows the plateau or worse, and then you go in lateral? Cora.
Yeah, you got it. So I typically don't test range of motion and tibial rotation. It's more of a symptomatic response rather than measuring the mechanical loss. So if they get worse in the sagittal plane, and in this case extension, I would just tend to go there because extension and tibial rotation typically are coupled.
I think I understood Dave amongst the faculty is the goniometer king, and so I was wondering how he might set that up to test for tibial rotation.
I use an inclinometer.
Oh,
he's got it in his pocket right now.
Inclinometer, yeah, I've got it right here. So I put the inclinometer on the tibial tubercle.
Yeah.
And normal motion is about 5 degrees.
Okay, so
and if it's less than 4, guaranteed it's going to need rotation.
Okay, fantastic.
So I don't think I ever tested, to be honest.
Yeah, use the symptom response to drive it.
It's like, you know, I look at flexion, I look at extension, and then I start moving them. And but you know, start the spine. You start with the sagittal plane, but if you get like an adverse response, then it's in my possibility of exploring.
Okay. Javad asks, in mobilization, could we use a lateral pressure, you know, manually on the tibia and femur to create some kind of varus valgus? Any thoughts about that needed of benefit? You've done it in the past?
I'll jump in on that one. When I teach that mobilization, I ask people to put the treatment table lower so that the elbow or the forearm, when you're pushing, you're actually creating rotation, and you're trying to avoid creating a valgus force on that. I'm not saying that you can't look at a valgus or varus force, but specific to that mobilization, I want to avoid that valgus stress and make sure I'm getting as much rotational stress as I possibly can.
Okay, good. Any other thoughts? Let's see, we got a couple of questions here. As exercise extension, external rotation with overpressure, you instruct Brian to activate the quads. Why? Anyone take that? Why do you?
Works better.
It works better. Very good. That's a good answer. Does everyone instruct that, the activating the quads? Gary, Cora?
Yep.
Yeah.
Start there. Yep.
Yeah,
Yep.
they're involved. They're engaged in the quad, and they're the extension component of it.
Uh-huh. Okay.
Yeah, Jason, I think this came up last week where, I mean, again, if we compare it to retraction overpressure, patient or clinician, what do? We ask the patient to retract actively and then have the pressure at the end of the range. And I think it's, you know, there's that methodology again, coming back. And we see so many knees that have that lack of terminal extension, some of them chronically. I think there's a motor control aspect. Maybe, you know, I can't prove that, but in my mind, it's like, wait a minute, that quad doesn't know how to take that joint into that end range, and it hasn't for a long time. So anything I can do to get that quad firing and then create that pressure into it, I think is of value. That's what I would argue. Now, a scientist may tell me I'm wrong, but, you know, that's at least my thought behind it.
Okay. Andrea's got a great question here in today's time. She noticed that you gave a lot of kinesthetic feedback to get the exercise right, and then you needed to do the overpressure. Today with telehealth, how might you account for that and adjust?
Cora.
Oh, thank you, because I do a lot of telehealth. So obviously we don't put our hands on the patients. when we do telehealth. So you just need to be a little bit more creative, and maybe instead of doing the mobilization, because why do we do the mobilization? We do it so that the patient will be more effective and treating, and obviously also to rule out irrelevant lateral components. So instead of doing the mobilization, then you just go right into the treatment component, which is having the patient perform the exercise with the foot out in external rotation and standing.
Okay. All right, good. We're at the end of visit number 2. Dave, you mentioned to us early on that you're more forward thinking in terms of preparing the patient for what you're going to be accomplishing or hoping to accomplish on the start of visit 3. What do you say to this patient, to Brian, at the end of visit 2?
Well, like I said earlier, so number 1, I'm going to make him demonstrate the exercise for me. Typically, I give patients a picture of the exercise. I have pictures of that exercise in my office. I'll often, if it's something like this, which is a bit more unusual for the patient to grasp, most people nowadays have a phone. I'll take a photograph of them doing it, or take a little video of them doing it. But I'll tell the patient, it says, okay, here's your prescription. I want you to do this exercise. My standard prescription might be 10 to 15 repetitions every 2 to 3 hours. But I want you to pay attention. I want you to pay attention to how it feels with day-to-day activities. I might well have him periodically do the squat. Sometimes I might have him do the squat pre and post home exercise. But then I'll tell him, I said, when I see you on Tuesday, or on Wednesday, whatever day, the first question I'm going to ask you is, were you able to do the exercise? The second question, were you able to do it as often as I want you to do it? The third question will be, what was the effect of doing it? Do you feel like it's making you better, making you worse, the same? So it makes them more accountable, because if they haven't done the exercise and they come back, they're going to be sitting there looking stupid. So I make them accountable. I make them to understand what they're doing, why they're doing it, and to be monitoring those symptoms. So you don't get that patient coming back going, so you're better, worse, the same. No, I'm better. It's like, yeah, but I'm trying to please you as a clinician. It says, no, I want you to be paying attention to it, paying attention to what's happening as you do it.
This patient surely didn't have any trouble with having motivation to do it, but we see a lot of patients that are in a position where their readiness just isn't there. How do you guys address that when you can see the patient will reduce likely if they just do what you ask them to do, but they just haven't made that commitment, or they're not quite there? Cora, start us off on that one.
Okay, I'm actually going to quote Gary on this, because I remember co-teaching with Gary a couple of years ago. I think it was part D, wasn't it, Gary? Or
Wait a
C?
second, this is the family show. You can't be quoting Gary.
Okay. No, so Gary said this, and I thought it was so beautiful. He said, he tells his patients with a smile on his face, your expectations should not exceed your willingness to comply. Did I quote you right, Gary?
Pretty
So
darn
that's what I would do, because I think the majority of the patients, if you show cause and effect, you can have them perform a painful baseline. You have them do a specific loading strategy, and then go back, recheck the baseline, and there's a huge change. You don't need to tell that patient what to do, because they know what they need to do. So if it's clear that there's something that they can do to make it better and they don't do it, then you've got a problem. You can lead the horse to the water, but you can't make it drink. So I would say that.
Anything to add to that, Gary, since you're the founder of that quote?
I think that quote came about while I was in pain management. So I was seeing a very chronic population, and they would give me the opportunity to see them 2, 3, 4 times, and not, even as Dave pointed out, not even if you put it in clear terms where here's what you do, here's how you do it, here's how often you do it, and here are the expectations should you choose to do that. After about the second or third visit, it was really kind of a call to say, okay, do I continue with this person or not? And so when they're looking at you going, I told you couldn't help me. And it's like, okay, well, I can't your expectations can't exceed your willingness to comply. So your willingness to participate dictates whether you're going to change or not. And so that I still stand by that even today. And I've got it written on my dry erase board at the top. So people, while they're sitting in my room, can sort of process, you know, that's probably true, you know. So, and I think that Dave's, you know, been pretty clear about that preparation of, and giving the expectation to the patient of, hey, you know, when you do this, you know, and it's like you're engaged with that patient. It's like, when you do this, this is what I'm looking for, and I need you to watch for it. So they know that it's not them going away doing some random exercise. They're going away and doing, you know, a certain thing with a certain expectation. As you describe that to them, then they know, oh, I got to go home and do this stuff, because if I don't, Dave's going to be asking me questions and I'm not going to have the answer for him, you know. So that's, I think that's super important.
Any final thoughts that you want to make sure we share with listeners tonight before we conclude in the last couple of minutes here? I've pulled everything that I'm going to get out of you.
I like that quote. There was a message across the board that somebody asked Gary to repeat it. I think he did, but you know, I think that's a wonderful quote. And I know from working with Robin, when he ran into a non-compliant patient, you know, he'd give him another chance. But if it continued, he'd simply dismiss them, and he would say, "Look, we've got so many people that need help. We can't spend time on people who don't want to help themselves." And Robin was always pretty straightforward with that.
Mm-hmm. Fantastic. Thanks everyone for your questions. Those of you who are on live tonight, we also want to thank Cora and Dave, Scott and Gary for your advice and your thoughts, your clinical reasoning tonight. We'll be releasing the third of the 3 videos later this week, so be watching for that, all those that have signed up to receive this. And of course, we'll be back here one more time to put up with me next week, Tuesday, 6:30 p.m. Central Time for that final Q&A. And we'll look forward to your questions based on that third video.
You know, Gary did have a great quote last week. It was so great, I can't remember it, but he had one this week. I'll try to remember. Gary, we need to promise one more quote next week.
Why do you think I wrote it on the dry erase board, Scott? Because I can't remember it either.
All right.
Great. All right.
Now you know our expectations. Next week, Gary, an amazing quote. Thanks, everyone. Have a great evening.
Thank
We'll see you in a
you.
week.
Thanks, Jason.
All right.
All right.
Okay, guys. We'll see you next week. Bye.
Thank you. Bye.
Bye.
Bye-bye.